Assalamu alaikum everyone and good morning. I'm Dr. Ahmed, fellow anesthetist at Shaukat Khanum Hospital, and I would like to welcome and thank you all for joining us in this session for anesthesia. I would request the chair of the sessions, Dr. Asma Ashraf and Dr. Sadur Rahman, to please come up on the dais. Thank you. So we'll be having 5 talks, 20 minutes each, and then there will be a 2 minutes break for the question answers in which you can ask any sorts of questions from the people giving the talk. And afterwards, we'll be having a panel discussion in which we'll be having a brief discussion. And again, there will be time for you guys to ask questions. So the first talk is by Dr. Jane Moriarty. I'll give you a brief introduction of Dr. Jane. She was the consultant in anesthesia and intensive care at St. James Hospital, Dublin. She worked as the chair of medical board and clinical director for surgery, anesthesia, critical care. She was also the former president of the College of Anesthesiology of Ireland and the former dean of the Joint Faculty of Intensive Care Medicine of Ireland. These are the few roles that she played out of the many she did. I would welcome Dr. Jane to please come on the stage and give her talk on prehabilitation, yes or no. Thank you, Dr. Jane.
Try and keep the time. Okay, so just while we're waiting, what I'm going to do for the next 20 minutes is talk through where we are with prehabilitation today and to look at the evidence base for prehabilitation. And as Dr. Ahmed said, I worked at St. James's. I have to put my hand up and say, now I am a lady of leisure. I retired recently. And I think this will be my last presentation. So I'm delighted to be here, and I would like to thank the organizers, especially Dr. Asma, for inviting me. I have no financial disclosures, and I have no conflicts of interest that I'm aware of. Okay, thank you very much. So these are my affiliations, St. James's Hospital, Trinity College Dublin, and the Clinical Research Facility, which is funded by the Wellcome Trust at St. James's Hospital. So if we look at what is the current advice, what's the current culture like around the management of the perioperative patient. If we look at the National Institute for Health Improvement in the United States, choosing wisely, their interpretation of choosing wisely is that the health professional should have the triple aims of using interventions relevant to the individual patient, improving the health of populations, and reducing the per capita costs of healthcare. The NHS Choosing Wisely UK has a slightly different interpretation and is more patient-centric and goal-oriented in the perioperative care. And there is a huge focus now on shared decision-making. So the acronym BRAN has come into being, and BRAN gives you the 4 questions that the patient should ask. What are the benefits? What are the risks? What are the alternatives, and what if we do nothing? And I think we've all been faced with patients where we should be considering the alternatives. We should be considering actually doing nothing. And occasionally we do nothing. When I say do nothing, we don't operate, but we put the patient into a different treatment pathway as a shared decision. Now, what does the patient need? Well, the patient's needs aren't always necessarily aligned with what the doctor thinks is best for them. So for the patient, they must have meaningful domains of patient-centered outcomes. So they're thinking, what is the impact on my life? What is my survival going to be? What is my patient satisfaction? So the patient reported and patient experienced satisfaction ratings. How am I going to be left after this surgery? What's my functional status? How well will I be? What will be my health-related quality of life? Well, they won't actually ask you that question because that's a very much a medically based term. And then for all of us, this comes, we all would like a good death for our loved ones and ultimately for ourselves. So we need to think about these from the patient perspective. So Levy and Selvin and Lobo published last year, turning waiting lists for elective surgery into preparation lists. Now you might say that that's a little bit of using healthcare rationing in a sensible way, because we all have waiting lists, and particularly after COVID, I don't think there's any health system that doesn't have waiting lists for elective surgery. So what's the best way to use that time? So in 2015, the National Institute for Academic Anaesthesia set out the top 10 research priorities in perioperative care. And one of them was, how can preoperative exercise or fitness training, including physiotherapy, improve outcomes after surgery? So optimizing the patient, we're looking at preoperative high intensity interval training, other forms of rehabilitation, the Prepare ABC, Fit for Surgery School, all of these interventions are designed to try to improve patient outcomes. So what's high intensity interval training? It is exactly what it says. We'll look a little bit at the figures for high intensity in the next couple of slides. It's been compared to moderate intensity exercise training, and there is no improvement using moderate interval exercise training in preoperative patients. However, with high intensity training, 75% of patients improved their peak VO2. And rehabilitation studies have been looked at in cancer surgery extensively, so head and neck, lung, upper GI, lower GI, urology and gynecology have all looked at rehabilitation. So we looked in St. James's at a feasibility study in 2015 using preoperative high intensity interval training. So our definitions, the interval duration was 15 seconds. The type of recovery, passive, we were looking for 100% of peak power output, which is the power output at the last fully completed stage of maximal CPAT, and that was measured in watts. Patients exercised for a maximum of 30 minutes or until exhaustion, dyspnea, or inability to maintain cadency of the ergometer at 60 revs per minute. And total exercise time above 80% VO2's peak is longer in protocols with passive recovery intervals, which is why we chose that. So what we know about we wanted to increase the training time spent at a high percentage of peak VO2. We know that it's safe in patients with coronary artery disease and heart failure, and it has a similar safety profile as moderate intensity exercise, but it produces greater improvements in fitness within smaller timeframes. So we looked at patients scheduled for colorectal and thoracic surgery. So we knew that patients with lower levels of cardiorespiratory fitness had increased risk of poor postoperative outcome. HIIT produces greater improvement in cardiorespiratory fitness compared to moderate intensity exercise. Low adherence is a big issue, and it has been reported in moderate intensity exercise programs, but it has also been reported in high intensity exercise programs. And we aimed to study the feasibility of a prehabilitation program using HIIT prior to major abdominal thoracic surgery. We had a single-arm feasibility study, and patients scheduled for thoracic colorectal surgery performed HIIT prior to surgery, and changes in fitness were recorded by CPET.
You have to change the slides. I think you have to scroll down on the slides.
Oh, yeah. Sorry, I wasn't. Sorry, wasn't watching. Anyway, I'll just go through where we're at in the interests of time. In the heel of the hunt, we actually only recruited colorectal patients, and we recruited 55 patients from the colorectal service surgery clinic in St. James's. All of these patients would come through pre-assessment, through my pre-assessment clinic, and they completed a variety of assessments, including cardiopulmonary exercise testing. All patients were put through the enhanced recovery after surgery program. And what we recorded were postoperative morbidity, mortality, and length of stay. I'm stuck. Must be started again. So I'll just talk a little bit about the trial results while we're waiting. I have some charts, but it's really just to show you the variance within studies of prehabilitation. So in our first trial, where we looked at the feasibility of doing this study, we had 20 patients who completed the intervention, 2 dropped out and 2 had their operations rescheduled. No adverse events associated with the exercise intervention. And there was high adherence and compliance, so 84%. Which reached statistical significance. That's okay, we're getting there. Okay, okay. So what did we find? Ventilatory threshold assessed via CPET was significantly associated with all complications with p-value of 0.03. Length of stay, again, ventilatory threshold was significantly associated with length of stay with p-value of 0.01. And participants with a ventilatory threshold of less than 11.95, so let's say less than 12 mils per kilo per minute, had a median length of stay of 11.5 days, and participants with greater than that had a median stay of 6 days. And there was no mortality within 30 days of surgery. Our patient feedback was excellent. You can see some of the comments there. And I know Mike Brocott from Southampton, who did some similar work afterwards, had very positive feedback from the patients who undertook prehabilitation. So we then went on to do a meta-analysis, a systematic review and a meta-analysis on the ability of prehabilitation to influence post-operative outcome after intra-abdominal surgery. So our database search, you can see here, 9 full articles were reviewed out of over 1,000. So we had, I think, 1,049 articles reviewed. Of those, only 9 were deemed to meet the criteria. So we looked at they had to look at population demographics, the type of operation, post-operative measures of outcome, the type of treatment of rehab and control, and have a control group. So only 9 articles included all of these. So we saw the rehabilitation to reduce complication, but the length of stay was not recorded in all the studies. Mortality was not recorded in all the studies. There might be a trend towards reduction in length of stay, but the methodologic quality was poor, and we really could not go on then to do a meta-analysis. It was not suitable for meta-analysis. So what are the challenges with rehabilitation centres? So the definition of rehabilitation: is it exercise? Is it nutrition? Is it multimodal? What type of exercise? Where do you do it? Patient cohorts are, of course, heterogeneous. Parameters reported variable, and the length of follow-up variable. Lack of consistency in reporting complications, and then some of the studies we looked at were inadequately powered. This is a review. Now, it is a 5-year review of 179 patients who underwent multimodal rehabilitation. So 80 of 179 improved their 6-minute walk distance by an average of 19 meters. And this group had decreased complications, well, but the p-value was only 1.22. 99 had no improvement. And then we were getting really into the swing of rehabilitation research and CPET. And obviously, for a lot, rehabilitation meant coming to the hospital. And this pretty little virus turned up and brought the world to a standstill. So we have had a slowdown in output in terms of the rehabilitation. So a couple of things that have been published in recent times. There was a Cochrane database systematic review published in May of this year, and it was rehabilitation versus no rehabilitation to improve functional capacity, reduce post-operative complications, and improve quality of life in colorectal cancer surgery. So they looked at 3 RCTs with 250 patients, and 130 had trimodal rehabilitation, which is exercise, nutrition, and anxiety reduction. 120 had identical interventions, but they only had these post-operatively. So that would be rehabilitation rather than rehabilitation. So the results really were that rehabilitation may result in improved functional capacity, may result in reduced complications, may result in increased readmission actually at 8 weeks. The interpretation of results, again, just like our study, the interpretation of results were difficult due to heterogeneity and bias. Looking then at where should rehabilitation be done, McIsaac published in 2020 a home-based rehabilitation with exercise to improve post-operative recovery for older patients with frailty having cancer surgery. Prehab trial, I'm sure you've heard of the prehab trial. And that was a randomized clinical trial. Mean age was 74 years, and 57% were female. So 534 patients were assessed, 254 were deemed eligible, 204 randomized, 182 had surgery. The mean duration of the program was 5 weeks. Now in our study and our target from diagnosis to surgery was actually 2 weeks. And pre-COVID, we were achieving in most patients, we were actually achieving a 2-week or maybe 3-week interval, waiting interval. The mean adherence, 61. So 5 weeks is quite a considerable period of time. But as I've shown you, because of the pressures on the system, it is often 5 weeks before patients actually get to surgery now. So the mean adherence was 61%. So what were the outcomes? Well, the primary outcome was the 6-minute walk test distance on the first post-operative visit. The secondary outcomes were physical performance, quality of life, length of stay, non-home discharge, obviously very important in the elderly population, 30-day readmission, and there was no significant difference. This is another publication in the last year, 18 months, and this is from a group in Budapest. Now, they had a slightly different interpretation, trimodal prehabilitation. They did home-based exercise. They randomized 149 patients. They had a 3 to 6 week program for the prehab group. They had home-based exercise with supervised weekly session, increasing exercise intensity. They used incentive spirometry. Now, we would not use incentive spirometry. I haven't seen that used for quite a long time. They used nutritional supplements as required and anxiety reduction. And the control group just had standard enhanced recovery after a surgery protocol. So the study group did improve their 6-minute walk test distance, but it was only statistically significant at 8 weeks post-op. The length of stay was the same, and the quality of life scores were better in the control group. The 7 and 30-day morbidity was similar, but an interesting comment in the paper was that the 7-day morbidity was lower in males in the study group. So the group felt that this needed further review, but they didn't comment any further in the paper. But there was it was postulated that males may not have been as fit as females starting out. They tended to be more overweight. They tended to have a higher incidence of hypertension, and they also were smokers. There was a higher percentage of smokers. So looking at habitability studies, a meta-analysis again in the Annals of Surgery showed that prehabilitation, this was an interesting one, and I think it just shows the dearth of good quality research. They looked at 177 studies and included 15. And of those 15, only 9 were randomized controlled trials, but prehab was shown to reduce the length of stay by just under 2 days with a p-value of 0.05, but didn't affect functional capacity or mortality. And this group looked at older patients undergoing colorectal surgery. Again, no difference in length of stay or postoperative complications. This was a paper by Gillis, showed that a combination of nutrition and exercise reduced length of stay by 2 days. There was a question as to whether it improved functional recovery, but not morbidity. So you get worried when you see a systematic review of the systematic reviews. That sort of rings a little alarm bell for me. But Mac Isaac this year published an umbrella review of systematic reviews. So 55 papers were included, and patients with cancer undergoing prehabilitation. So moderate evidence for improvement in postoperative functional recovery, but low evidence for reduction in complications, non-home discharge, or decreased length of stay. And this one, again, looked at a very small number of patients, but no improvement in preoperative fitness. Again, here we have another one looking at deconditioned patients in lung surgery. So 77 patients, randomized controlled trial, 74 in the HIT group, 77 usual care, CPET and 6-minute walk test pre and post training. 8 sessions was the average done, and HIT improved aerobic capacity and power, but not outcomes. Fit for Surgery was one that I thought was interesting because it's an app with biofeedback where you deliver a prehabilitation at home before and after elective lung surgery. 10 exercises, 3 minutes each, an app, a smartwatch, and control attended prehab sessions. But interestingly, the app patients did 4 times as many sessions as the control group. And the app patients improved their incremental shuttle walk test by 99 meters. And that is statistically significant, but did it matter in terms of outcome? No. So this is the Southampton group under Mike Grocott, Fit for Surgery cancer trial protocol, which was published, which is ongoing at the moment. Randomized controlled trial, 4 arms, 1,500 patients, usual care, 2 to 3 is the control group, 2 to 3 supervised HIIT sessions per week, psychological support, or exercise and psychological support. So what are the endpoints? Length of stay, disability adjusted 1-year survival, post-operative morbidity, health-related quality of life, 30 days, 12 weeks, and 1 year. And the other studies that are in progress from our own group are preoperative exercise looking at fitness in complex surgery for lung cancer and esophagus, pre-HIT, and the effect of a pre and post-operative exercise program. This is being done in the in one of the other hospitals in patients who are undergoing esophageal and gastric surgery, who are undergoing neoadjuvant treatment prior to surgery. And if you remember, I did say these were a particularly vulnerable group coming for surgery. Challenges: it's expensive, it's a time-intensive intervention. If there are minimal gains, then the money could be better spent elsewhere. Getting to the patients who need it most, socioeconomic barriers definitely play a part in a patient's attending hospital if they need to come to hospital, and in complying with the advice, such as other preoperative interventions, such as cessation of smoking. So you've got to have patient buy-in. Recruiting the numbers for the RCT is slow, so multi-center trials are required. Adherence, we've already discussed, it tends to be poor. And can home-based be successful? Well, the results are mixed so far, but it is something that I think merits looking at. So as your kids say when you're on your way to your holidays, are we there yet? No. Current evidence does not show definitive clinical effectiveness for rehabilitation. Published results to date are largely based on systematic reviews with heterogeneous cohorts and methodologies prone to bias. And we are awaiting a number of large RCTs. So I leave the last, the summary here to Manila from 2020. So rehabilitation prevents functional decline associated with major cancer surgery, but evidence is still needed to support its effectiveness in relation to post-operative complications, length of stay, tumor progression, response to medical treatment, and survival. And survival and tumor progression, I think, are always uppermost in the patient's mind. So ongoing future research is essential to prompt the role of perioperative medicine in cancer care. Thank you very much, and I'll take any questions.
Thank you so much, Dr. Moriarty, for this excellent talk. And it seems that rehabilitation is a compelling strategy, highlighting the role of anesthetists as perioperative physicians and shifting the paradigm from the risk assessment and prediction to risk attenuation, actually. So my question was, in the context of the cancer surgery, you mentioned that the optimal time duration for the prehabilitation is 2 weeks. And you know, the hospital policymakers all over the world, actually they take the wait time as the benchmarks. So that I think puts a lot of challenge for the physicians and probably the surgeons as well to rightly, at right time, refer the patient to the preoperative assessment clinics. So do you have the prehab clinics incorporated in the preoperative assessment clinics? And what are the referral criteria so that at least the high-risk patients, the cancer patients who are frail, elderly, can be screened at earlier stage to optimally utilize the resources?
Well, I think when I was running the preoperative assessment clinic, we were doing quite a lot of research. So we were working with the group in Trinity College who are physios. It's the professor of physiotherapy is one of the lead researchers. And my PhD student, Jonathan Moran, who did that work, was a physio, is a physio still. So I think you've got to look at what resources you have in the hospital. I think you have to have a very good working relationship with your surgical team. And I had the patients, I was already getting patients sent to me as urgent. Could I please see them, trying to get ready for surgery in 2 weeks' time. Now, the interval from diagnosis to surgery has gone way out with COVID because of waiting lists and theatre, issues with theatre accessibility. But we did have quite a few patients within that 2-week period, and I think it's a very tight time frame. But you've got to get the patient the day that they're given the diagnosis. Patients, the day they're given the diagnosis, aren't hearing what's been said. They only hear cancer, that's all. And what we did then was we started bringing the patients back maybe 2 days after they got their initial diagnosis. I would meet them, or I would meet them in the clinic on the day they were given their diagnosis, because our clinics were adjacent, and then have them come for preoperative assessment. And I don't think, and we'll look at it in the next talk actually, I don't think that we will get every patient to prehabilitation, but we can give them advice. And I think that this is where maybe the home-based prehabilitation might come in for a lot of patients. And then for the higher risk patients, getting them into a preoperative with supervision and with physiotherapy. And that there's quite a lot, there's a big group now. The physios will take maybe, well, obviously it came to a complete end with COVID, but before that, they might have done a class with 10 patients coming, and it will be the same people coming together. And we found that was really, from an anxiety point of view, that actually reduced patient anxiety. And a lot of those patients stuck together and exercised post-operatively and still met, because I would meet them when they were coming for their pre-assessment for their, if they'd had a stoma, for reversal of stoma. So a lot of them, and this is anecdotal, but a lot of them said to me, well, we still meet the lads, still meet the lads, and we still exercise once or twice a week. So, I think that was an intervention that has lifelong effects. But yes, you absolutely have a tight window, and you have to have, I think, professional physio input for the patients who really need prehabilitation. And that's where we really need to focus, is who really needs it.
Thank you very much. If there are any other questions from the audience. I have a couple of questions. I couldn't get a sense of what your personal views are regarding rehabilitation. So if you could elaborate on.
See, this is where bias comes into it, because I was a real believer in prehabilitation. I really believe that exercise, I believe that exercise is good for you. There's lots of evidence there that exercise is good for us all, and I really did feel that we were onto something here. But the evidence to date, and I'm not sure, is it prehabilitation, or is it just that the trials that have been done to date have not been of an adequate quality and haven't been adequately powered? And there are some benefits to, some tangible benefits to when you're measuring on a scientific basis, but from a point of view of the patient, you saw the feedback from our patients, and that's actually universal. Anybody who looks for feedback on these studies does get very positive feedback. Now, again, that might be biased, and there were some comments to say from Mike Grocot's, some of Mike Grocot's colleagues, but perhaps they're afraid to tell you that they didn't like it in case it in some way has an effect on their outcome or how you treat them. But I'm still a believer that there's a cohort of patients out there that benefit from prehabilitation, and it has been used in other modalities of treatment, like for cardiopulmonary disease. Non-operative, but I do think that the quality of research has actually been quite poor, and that we're struggling with that then to show benefit. But we do need big trials. We need big data.
I have a question actually. In the in your experience and from the evidence we have, is there any subset of patients who do particularly better compared to others? Because it's a very heterogeneous population in this study.
Yeah, it is really heterogeneous,
yeah.
And that is one of the real problems. And then if you're looking at, say, lung cancer patients or colorectal patients, I think you've got to do multi-sector trials to try and get the numbers up. There is some evidence, I think, from the lung cancer group that they may have better outcomes, less complications, but not anything that reaches statistical significance.
Part B was, how do COPD patients fare compared to others in upper GI or upper?
Well, it's the COPD. Are you saying COPD patients coming for surgery or the COPD
patients coming for surgery, so undergoing rehabilitation?
I can't answer that question because they are a group that I feel should have it, but I can't answer the question in an evidence-based way because the evidence isn't actually there. And that is the problem with the studies, that they are heterogeneous. You don't know much about the baseline of the patients. So that study, let's say, that like the silver bullet study has not been done yet.
Thank you.
Thank you.
Thank you very much, Jane. If you would join us in the panel and
sorry, I just have a short question, Jane. Sorry.
Oh yes, sorry.
I just make small comments. Like we in our Shaukat Khanum hospital, we don't have an established practice of doing pre-rehabilitation in our pre-anesthesia clinic. But at least in my own clinic, pre-assessment clinic, I do advise. It's simply home-based. We don't have a system of physiotherapists available in the hospital to do pre-rehabilitation. But we do advise few steps for the patient, whatever time we have got for the patient before the actual scheduled surgery, to go for the some sort of physiotherapy, incentive spirometry, nutrition advice. Okay, it's not well-established program, but we do start doing something to increase the functional capacity of the patient before scheduled surgery. Just the comments.
Yeah, well, you saw that group from Budapest. They did show with trimodal rehabilitation, exercise, nutrition, and anxiety reduction. And they used incentive spirometry. There were improvements in patients. So, thank you.
Thank you, Dr. Jain. And if there is any other question, we can take that at the end of the session. And you're all more than welcome to ask your questions at the end of the session. So we'll continue with the talks. And the next speaker is Dr. Ehtesham Khan. He'll be talking about patient safety, what we know and where to go. So I'll give a brief introduction of Dr. Ehtesham. He's a consultant anesthetist intensivist in Ireland. He was elected as the member of Council of College of Anesthesiology Ireland. He is the chair credential committee of College of Anesthesiology of Ireland and the former vice president of College of Anesthesiology Ireland and board member of National Office. So I would request to please this will be an online talk, so please
I would like to thank Dr. Asad and Dr. Asma for inviting me to give a talk at the Symposium on patient safety. It's an important area in healthcare, and you can have 2-3 day masterclass on patient safety, but I have only got 20 minutes, so I will try my best to talk on 2 to 3 themes in this area in the next 20 minutes. But before I go into detail in patient safety, I just want to show some facts, figures, and numbers. If you look into the top left part of my slide, you can see top 10 causes of death. And in that, after surgery or within 30 days after surgery, the number of patients who die are more than 4 million. and that is more than combined deaths with HIV, tuberculosis, and malaria. And by this, we know elephant is in the room. And after investing or putting billions of euros and dollars in healthcare, approximately 15% budget goes in dealing with the errors and mismanagement in the healthcare setup. This study further states that half of these deaths occur in low and middle income countries. Dr. Tedros, who's the Director General of World Health Organization, also mentioned in his 2021 and 2022 annual report, 5 patients die every minute because of unsafe care, and also 5 billion people around the world don't have access to safe surgery. And if you look into the slide on the left, sorry if you can't see the numbers, but the colors will tell exactly what I wanted to say. The red area is where there is less than one physicians per 100,000, and dark green is more than 20 physicians per 100,000. So if you look into the population of the world, mostly is in Asia and Africa, have got less physicians. So if you have got less physicians per 100,000, that will lead to unsafe patient care. I took this slide from Patient Safety Movement Foundation, and you can see what they are saying. 3 million people estimated to die globally each year from medical errors. And what they aim to achieve by 2030, 0 preventable patient harm by having right ideas, right people, and technology. To me, it looks very optimistic, but the foundation thinks even 1 is too much. So let's see how they come to 0, having preventable patient harm in the next 8 to 10 years. After some facts and figures, I want to come back on my presentation on patient safety. One area nowadays being discussed in safe patient care is managing fatigue as part of safety culture. In the last decade or so, there has been an increased awareness and understanding of effects of fatigue on both healthcare workers and patients. In 1998, the European Time Directive came, and the time per week for the junior doctors are reduced to 48 hours per week. And in most countries, European countries, that working time directive is enforced. But what they didn't mention or looked into, there is no guidance about the provision of minimum standards and facilities for the doctors and nurses while they are on call. In this slide on top left, it's Dr. Ronak Patel, who was a trainee anesthetist, and after 3 consecutive nights on call, was driving home. He fell asleep on wheel, and he crashed his car to a lorry, fell in ditch, and died on the spot. He was so tried while he was driving home. To keep him awake, he rang his wife, and he was singing while driving on the phone. And his wife realized that he had stopped singing and tried to call him back a few times, couldn't get through. And later she came to know her husband died of a traffic accident. In the slide at the bottom, she is an accident and emergency nurse working in the trauma area. She, after a busy on-call night, was driving home, fell asleep, and on a road turn, she hit the truck and she died on spot. The picture on the right top is an Irish nurse in the south of Ireland. After a busy night on call again, she crossed onto the other side of the incoming traffic and hit the Land Cruiser and died on spot. There are a lot of cases reported like this and come into the media. Healthcare staff driving home tired and ending up having an accident. This survey was done in 2017 and looking in fatigue in training and consultant anesthetists. If you look into the training column, Car accidents and near misses by trainee anesthetists post nights, 57% reported they had it. And if you go down, and 84% of the trainee mentioned they were too tired to drive. And only 64% have an access to reasonable shift or facilities when they're on call. In the lower bottom, you see is a very high percentage of the doctors mentioning fatigue having an adverse effect on their physical health, psychological well-being, and their family relationship. Few facts about fatigue. Most adults require 8 hours of sleep per night. Sleep debt can occur after we have 2 or more nights of restricted sleep. And it will take 2 nights to recover from sleep debt. Cognitive function is impaired after 16 to 18 hours of wakefulness. And if you drive after 20 hours of awake, it is just like having a blood alcohol level in your blood more than the Irish limits. And we all know if you're tired, it's illegal to drive. You're twice more likely to crash after 12 hours of work than 8 hours per day of shift. And fatigue also leads to spontaneous, uncontrolled lapses and microsleeps. And as we age, the sleep depreciation gets worse. So if you look into what can happen with the healthcare staff, it can lead to more accidents, diabetes, hypertension, may lead to stroke and some types of cancer and also peptic ulcer. But more importantly, if you look into the patient size, the healthcare staff will lose empathy towards their patient, logical reasoning, and also the vigilance goes down, their mood is down, and also to ability to retain and learn also goes down, and that will have an impact on patient safety. From this slide, you can see we, the humans, are daytime creatures, and our temperature goes down in the night. Our alertness goes down in the night, and also the performance as the evening progresses goes down, and that lead to more risk of accident. So how we can manage this issue? The first thing I would say is education. The healthcare staff themselves should know about fatigue and the consequences of fatigue. And this can be done by education for the healthcare staff, and also this should be directed towards the hospital management as well. And there should be resources available for that, and that could be teaching resources, posters. And once you have identified the issue, in this instance, fatigue, then you can look into the remedies for this. So for instance, in this incident, in terms of fatigue, what could be done is you can have more staff on your rota, and that will lead to less frequency of on-calls, and that will lead to a better rota with decent breaks. And there should be a compulsory rest period before on-call and after on-call activities. And while you are on call, they should be built into the staff rota, should have enforced breaks. Power nap, I think most of us know the importance of power nap. In airline industry, especially for long haul flights, this rest period or power nap is built into their schedule. If you take a power nap, and what does power nap mean? It's 20-25 minutes, but to go to sleep, you need 5 to 10 minutes. So it's around 30-35 minutes of a break. And it should be in a quiet room that should be provided by the hospital administration. And you should not be carrying a bleep or phone while you have got that break. And as you can see on this slide, if you have a power nap and you come back, it improves your alertness, your memory improves, your faster reaction time, better learning improves. And so it has got a very positive impact on it will lead to a very positive impact on patient care. Now, moving to my next part of my talk, This photo is of Charles Cullen. During, he was a nurse, and during his 60th year of nursing career in New Jersey, he was involved in murder of several patients, and he was arrested in 2003. He confessed to murdering at least 29 of his patients. He had a history of mental instability and number of deaths during his employment at various hospitals, but there was no reporting mechanism to identify nurses with mental health or employment problems. Liability concerns were there for the hospitals, and they were unwilling to take action against Cullen. And Cullen moved from facility to facility undetected, and because there was no requirement to report suspicious behavior. And the hospitals were also afraid of getting sued if something goes wrong. And but in 2004, Patient Safety Act came in and increased the hospital responsibility for reporting serious preventable adverse events. And in 2005, there was another supplement and required the hospitals to report certain details of also of the employees. This is another case of an Irish obstetrician. He worked in the same hospital where I am working at present, but he was long gone before I joined that hospital. And the investigation found that he was doing unnecessary surgical removal of wombs, mainly after delivery of baby, what we call it cesarean hysterectomies. During the 25 years where he was practicing, when he was practicing in that hospital, there were 188 cesarean hysterectomies done. And out of that, this doctor did 129 hysterectomies. Just to mention, in the average consultant obstetrician will do 5 to 7 this kind of cesarean hysterectomies during their entire career. So there was no one reporting this unexpected cesarean hysterectomies being done. The numbers were so high, but nobody reported about Dr. Michael Ranieri. And in the hospital, he was very, very respected physician. This is another case, a very famous case in United Kingdom, late 90s, Dr. Harold Shipman, GP. He was involved in more than 200 of his patients, giving them diamorphine and involved in their death. There was no data collection in those times. He was in his general practice. There was statistically more women were dying, but there was no mechanism. Nobody reported this GP. And in 1999, he was found guilty, and he was sentenced to long-term sentence to the jail, but he hanged himself in 2004 in jail. If you don't report these type of incidences, so this type of a behavior can take place in a hospital, and the two basic principles, beneficence and non-maleficence, are violated if you don't report this type of behavior. We should have a reporting mechanism, but we also should make sure there is a no blame environment as well. And for that, the first thing is we should have the right process for all that. You cannot consistently produce good results if you have got the poor process. And if the system or the process is bad, it will always beat the good person all the time. So moving to my last part of my talk. So at a national level, we should have an investigation body or a commission or an authority. And the government's duty is to protect their people. We have got armies, we have got disaster management process. We do get rail or air inquiries if there is any accidents. So if that's the case, why not a healthcare investigation body? And in healthcare, there are more deaths compared to the other areas which I have mentioned. This is a very famous case in England, Elaine Bromley in 2005. The top left picture, she's there, and her husband, Martin Bromley, who's a pilot. She went for a routine surgery in 2005. Plan was to put a supraglottic airway, and anesthetist with a 16 years of experience wasn't able to ventilate and oxygenate, kept on trying. Patient desaturated down to 40, and after 15, 20 minutes was able to secure the airway. The ENT surgeon was present in the room, and nobody took action to plan something out of the box. The nurses, some of the nurses, it sounds like a prompt as well to get a front of the neck access, but nothing was done. Patient had an anoxic brain injury, and she died after 13 days in the hospital. Martin Bromley as I mentioned, is an airline pilot, was looking for the answers. What happened to his wife? And after a few months, he got all the answers, and he knew what exactly happened. And what good thing Martin Bromley did, rather than criticizing the whole healthcare system, he investigated the human factors involved in healthcare management. He was a pilot, and he formed human factors group, clinical human factors group, and looked into how the system and process can be improved to provide safe patient care. As he was an airline pilot, he knew in airline they face complex tasks where human life is at stake. And what they do, they have got a standardized operational procedures, leaving as little possible chance for frailties of human psychology. But most importantly, there should be a system for blame-free reporting, and in the wake of any disaster investigation that seek essential lessons rather than looking for scapegoats. I'm running short of time. I quickly mention another case, Mary Combe Bay report, where 11 babies died and 11 babies and mother died. On the left, I've just mentioned, I've highlighted in the bold. It found out poor clinical competence in that hospital, a poor relationship between the doctors and the midwives, and significant organizational failure. So in the last two cases or two investigations I have mentioned, that shows the importance of national healthcare body or an organization. It's not easy to set up these. I do understand there are a lot of issues. Who will investigate, the cost coming up, the expertise around it, but that should be the way forward. And in most of the European countries now, there are investigation bodies or authorities established. On the right, there are three bodies or authorities which I've shown. On the right is in the Norway, which takes they started a bit early. So they have got a National Commission for Inquiry. They look into if anybody reports. They have got this inquiry commission. And in the middle photo is, or the picture is in the Irish, we have got HICWA, similar pattern of that. They themselves also go, but if there is any reports or incidences, they go and look into the hospital. And onto the left, it's the English, the Health Safety Investigation Board. They were a branch, but next year they will become an authority. So these are the investigation authorities in the healthcare system. Very autonomous and looking into the system and process if anything goes wrong. So from this slide, you can see some, there may be an opinion whether all these health safety in healthcare work or will they work. But if you look into this data from 2006 to 2021 in air traffic fatalities, if you see there's a downward trend. What they have done, they have looked into if there was any accidents, why that accident happened, was there a human factor, was there any mechanical factor, and they kept on improving their system, and the trend is downwards in terms of the fatalities in air traffic. Not sure how many of you follow Formula One. The photo on the left, it's of Ayrton Senna, and the right is Dr. Sid Watkinson. a neurosurgeon, and he's also a chief safety, medical and safety officer, was in Formula One. Senna died in accident in Formula One in 1994. Dr. Sid was a very good friend of him, but rather than sitting back and saying to the driver, slow down, he started looking into what could be done to improve Formula One racing. He improved the medical facilities after an accident, emergency medical facilities after an accident. He had a very important role and strong role in the governing body of Formula One. And he improved a lot of things in the systems and improved a lot of safety features. And because of that, since 1994, there has been only one death in Formula One racing. So that shows if you have got the system and the process, things will improve. And what we should try and reduce the opportunity for error. And this will lead to the opportunity for recovery as well. And further going down, this will lead to reduce the consequences of error. And the ultimate beneficiary will be patients and will lead to a safer and better healthcare. Thank you for listening.
Thank you, Dr. Sham, for this little talk. Have we got Dr. Sham online now for questions?
He'll be joining us in just 30 seconds.
Okay.
So meanwhile, if there is any question from the audience, they can come up to the mic.
I just have to make one comment. That is because this talk is so much relevant, and Dr. Sham has very rightly pointed out about the health of healthcare professionals when it comes to patient safety. Because we as healthcare professionals, we are the one who are providing the care. So we should take care of our health as well. And we have a lot of residents here, and I can see many nurses here, the junior nurses, as well as the senior nurses. I suppose there will be a lot of questions, because I feel that clearly when it comes to patient safety, anesthesia has improved a lot in the last century, actually. But unfortunately, this improvement is not consistent across the globe, because when we talk about the national database, when we talk about the trained professionals and the resources, so we come to know that it is so variable among different countries, and even in different parts of the same country, like the way we have in Pakistan, that even in Lahore, I don't think so there is any at local level even, there is any process of reporting the patient safety events, so that we can learn from our mistakes. You know, that culture of learning from incidents, that each error we make is an opportunity to learn. And that awareness that the individuals who are involved in the patient safety events, they themselves are the victims, and they need support from their peer. And from that point of view, I would like to say that in the hospital itself, in Shaukat Khanum, we are trying our best to inculcate that culture of creating an awareness of open communication, talking, and the concept of giving support to the second victim. So if from the audience, especially the residents and nurses, if there is any comments or questions, they're most welcome.
So Dr. Sham, if you can hear me, I have one question. So we've talked about the role of the governance making bodies or people who are in charge of governance regarding the safety. But what, in your view, is the role of the clinician or the nursing staff in everyday patient regarding patient safety?
Thank you, Saad. Can you hear me? Saad, can you hear me? Saad, can you hear me?
Can you hear me?
Yes, sir, we can hear you loud and clear. Thank you.
Okay, thanks, Saad. Saad, the topic, Dr. Saad and Dr. Asma, thanks for inviting me for this talk. The three themes which I have spoken to, fatigue and reporting culture and having bodies, and that's particularly reason is I've chosen is because of Pakistan. Because in Pakistan, I think from the rota point of view, the doctors, the nurses, the way they work, there are no facilities. And secondly, there is no reporting mechanism. If somebody has got a very leadership role, nobody complains of them and anything goes wrong into the system. And what you have asked Dr. Saad about what the clinicians can do, I do understand in a country like Pakistan, where it's very difficult at a national level to set up this thing, but at least the clinicians or the hospital where you are working, you can do. And I can give you one example. The hospital where I work, and I think in most of the Irish hospitals, we have got SIMF, that's a Serious Incident Management Forum, where anyone can report any incident or to the risk manager. And once that case has been reported, any mismanagement of a patient or any mortality or a morbidity, that case does get discussed in the Serious Incident Management Forum, and we do it every month, and I'm also part of that. So at the clinicians in Pakistan, say for instance, I think definitely in Shaukat Khanum, there will be a setup. I know in Aga Khan, we do look into that sort of incidences, but that should be the case where clinicians can go and make up their own sort of a setup there where any serious incidents can be reported, and it can be anonymous and could be done. And one more thing is, it should not be pointing towards somebody has done something wrong, but that should be always directed towards to improve the system. And so I think that's what physicians can do or the clinicians can do in Pakistan.
Is there any other question? I have just another question about the role of the simulation in the training and learning for the healthcare professionals.
Dr. Asma, again, it's a very good area. Similar to simulation, College of Anaesthetists in Ireland, every year we are increasing the more and more scenarios. We have gone up to, like, say, I think 11 or 12 in intensive care as well. We have got few simulations, and we kept on increasing them, and that's a good way of training the doctors, the nurses, before they go into a real life. And one more thing is, other than the simulation, the work-based assessments as well. In college in the Western world, England, Ireland, we now have introduced work-based assessments as well. And so along with the simulation, work-based assessment is also very important to see how the doctor is performing or the nurse is performing any procedure, and that could help in their improvement as well. So simulation, definitely, and I think that should come into the College of Physicians and Surgeons as well. As far as I remember, we don't have any simulation to do before they are signed off. Am I right? But it should be the case.
Thank you so much, Dr. Ehtesham. So if there is any other question, you can ask that at the end of the session. We'll continue with the talks ahead. And our next guest speaker is Dr. Mansoor Nawaz Pangish. And I'll just give a brief introduction for him. He's a consultant anesthetist intensivist at University Hospital Birmingham. He is honorary senior lecturer, and he has extensive publications, over 40, on the subjects of liver failure, sepsis, AKI, ARDS, and COVID-19. So please welcome me in joining Dr. Mansoor Nawaz. His topic is acute kidney injury in major non-cardiac surgeries.
The hospitality that you've shown us so far. Is it going to load up? Okay. All right. Okay. Okay, so I'm going to talk to you about major acute kidney injury and major non-cardiac surgery. Just a few declarations to begin with. I've received some small amounts of research funding from these three organizations, none of which have anything to do with acute kidney injury and major non-cardiac surgery, although NephroCheck have provided some funds for acute kidney injury research in liver transplantation, which we're not going to talk about here, but we'll talk about are these four areas. And I'm going to start off by talking about the definitions of acute kidney injury. And I'm sure that you're aware that it's all based on a fold change of baseline creatinine of either 1.5, 2, or 3 for the 3 grades of kidney injury. There's also some absolute criteria which simply increase the sensitivity of AKI detection for people with higher baseline creatinines. And these fold changes need to happen within 7 days of a defined insult, which in this case is the operation, obviously. There's also some urine output criteria that are equally important when we don't measure blood tests, but you can read those there for yourself. What you're probably less familiar with is a relatively recent concept of acute kidney disease. And this is simply an acute kidney injury that persists for longer than 7 days. And essentially, because the dysfunction persists for longer than 7 days, it's thought to represent either ongoing injurious processes in the kidney or a failure to recover and regenerate within those, beyond those 7 days. And unsurprisingly, it's very strongly linked to CKD progression beyond recovery. So talking about these longer term endpoints brings us to renal endpoints that have been defined specifically for perioperative medicine. And these borrow the concept of a composite outcome from cardiology trials where they have major adverse cardiac or cardiovascular events. But in this case, we're looking at major adverse kidney events. And these are a composite of any of the three of a substantial decrease in eGFR, any need for renal replacement time during the period of time for which we're looking at these outcomes, or all-cause mortality. And these definitions will become a little bit more important as we proceed. So what's the epidemiology of perioperative acute kidney injury? Well, there's lots of studies on acute kidney injury, not that many in non-cardiac surgery, but the few that we do have are actually quite large and pretty good quality and come from a variety of backgrounds. They have their drawbacks though, and the first is that not many of them actually look at major non-cardiac surgery. They lump all patients together who are having non-cardiac surgery. The second is that they also tend to lump elective and emergency patients together, and it's my understanding that they have a very different sort of pathophysiology. Furthermore, the outcomes, although they're now defined by KDIGO, according to the criteria we saw earlier on, a lot of the studies look at different temporal criteria. And you can imagine a patient that develops AKI at day 28 of a stay is likely to be very different to someone who develops AKI at day 2 of a stay. And so we wanted to get around these problems because obviously these studies produce different outcome rates for their study target of interest. And so we wanted to get around this problem. And what we've done is we've looked at roughly 5 years worth of data from our own trust before COVID so that there's no COVID contamination. And we found that in a strictly elective major non-cardiac surgery group, the rate of AKI is roughly 9.5%. But that belies a great variation in AKI, so that you can see here across different subspecialties of major non-cardiac surgery, there's very different rates of AKI, with neurosurgery having the lowest rate of just sort of 3.5%, and general surgery having the highest. We also looked at the pattern of distribution for these AKI problems that appeal, and essentially the prevalence of peak AKI is highest in the first couple of days after surgery, but then falls off, but then has a second peak at day 6 or 7. So according to the KDIGO definition, this is still a kidney injury that's caused by the operation. But the secondary peak that you see here suggests that actually there's a secondary pathophysiology going on. If we break it down into what the different grades of AKI are, you can see that overwhelmingly most patients have a grade 1 acute kidney injury. But the rate of that falls across over the 7 days and is matched by an almost identical increase in acute kidney injury grade 3. So that by the end of day 7, roughly 50% of patients will have either a grade 2 or a grade 3 kidney injury. So we wanted to understand what was driving this, and we looked at patient and surgical risk factors. And unsurprisingly, the type of surgery that the patients have are very strongly and significantly linked to the risk of AKI, again, with the highest risk being for general surgery. But we wanted to drill down a little bit more into this. And what we found was that actually it was the anatomical compartment that was being operated on that made the difference. And essentially entering the peritoneum rapidly increases the risk of acute kidney injury. And that's suggested here by this study looking at laparoscopic versus open surgery with rates of AKI on the left and survival on the right, in both being significantly lower for laparoscopic surgery. Looking at patient risk factors, we found that there was a dose response between age, EGFR, and the risk of acute kidney injury. And furthermore, male patients were much more likely to have acute kidney injury as well. More interestingly, because these are probably quite expected results, but what was slightly unexpected was that we found a dose response between the severity of hypertension and also the degree of tachycardia that these purely elective patients have at baseline and their risk of acute kidney injury. We also found various other risk factors such as even mild anemia, hypoalbuminemia, and bone marrow markers of inflammation being linked with acute kidney injury. And because many of these factors overlap, so for example, a patient with cardiovascular disease may well be hypertensive, may well be on an ACE inhibitor, may well have diabetes. We went to a multivariable modeling to try and tease out what were the actual independent drivers. And what was interesting was that we began with roughly 50 or so variables. We ended up with a model with just 31 variables, but during that modeling process, age fell out of the independent driver. What did remain were these factors, which were the biggest risk factors for acute kidney injury. Very interestingly, what remained as independent drivers of acute kidney injury were the presence of anemia, inflammation determined by bone marrow markers, and baseline heart rate again. And we're not entirely sure why we got this result. There is, of course, a possibility that the model is flawed, but what we think is that actually the cluster of variables that we've got very accurately defines biological aging, and that's probably why chronological age then falls out of the model. So does this really matter to patients? Well, we know it's common, but actually, if you look at the outcomes with these patients, what you find across many studies, including ours, is that there's a severely increased odds of death in hospital if you have acute kidney injury. As far as the inpatient stay is concerned, even if you survive, you've probably got a double duration of inpatient stay, incurring higher hospital costs and resource utilization. And of course, as expected, the risk of RRT is really massively increased in these patients. Furthermore, if you think that this is something that just affects people with grade 2 and grade 3 injury, actually even a grade 1 injury will increase your odds of dying in hospital by roughly 2.5. And that's data from the ISOS study from several low, middle and high income countries. This extends out to the long term as well, so that the survival problem judged in this prospective observational study was shown for even mild injury in the pink line and also for moderate and severe injuries as compared to no AKI in the blue line. And this study looked at these MAKE-365 outcomes that I'd mentioned to you earlier on and found that they were much more likely to occur in the patients even with a mild kidney injury. So twofold increased odds of the risk of a MAKE-365 outcome. Now, as I've said, this is a composite outcome, so it's important to drill down into which of these composite outcomes is driving this. And this Venn diagram shows the numbers. And essentially, we know that survival is a problem, but if you take death away from here, what we find is that 20% of the MAKE-365 outcomes are actually driven by CKD. And so what this means is that if you have an idea that a patient will come in with a basal EGFR, which gets knocked off by AKI, and then they'll recover and go back to normal, well, that's just not really correct. And in fact, what's much more likely to happen is that these patients will return to a GFR, which is worse than beforehand. And in addition to that, they will get the added insult of accelerated decline. So why does this happen? What can we do about it? Well, we know that there's roughly 1 million nephrons in each kidney. And we can demonstrate that here or represent that pictorially just by an array of roughly 48 nephron units across 2 kidneys. These are happy nephrons, they're green. The GFR is 120, I'm telling you. And the work that they do is roughly proportional to the renal plasma flow across these 48 nephron units. In this example, we're going to give the kidney an injury, and what will happen is that we'll lose roughly 2/3 of the nephron units. With that, you'd expect the GFR to drop to 40, that's 2/3 of 120. But actually what in this example, it's higher than that. I've said 50. And the reason for that is because the remaining good nephrons, they increase the amount of work that they do through compensatory hyperfiltration. And the way they do that is that the tubular cells, they hypertrophy, they increase their DNA content, and they become what's called polyploid. In the case of a patient with CKD with maybe half the nephrons of beforehand, you'd expect the GFR to be 60, but these nephrons are already hyperfiltering, and that's well established in CKD. They get a much smaller injury to bring themselves to the GFR of the other patient, because they only need to lose roughly, in this diagram, 8 nephron units. Again, you would expect the GFR to drop to roughly 43, but it comes back up to 50 because of compensatory hyperfiltration. So, I mean, that kind of just explains what you probably already know. You get a kidney injury, you lose nephron function. It's not particularly insightful. But what I've tried to show you over here is that actually this idea of binary states of nephron happiness is wrong. And even at baseline, the nephrons exist on a spectrum of robustness and metabolic function. So that the really happiest sort of nephron units are over to the left. They're very robust. They don't mind a little bit of a drop in oxygen supply. They're not particularly immunogenic, and they're very resilient. Whereas over towards the pale green and the amber, you're much more likely to be on a metabolic knife edge, so that any drop off in flow and nutrient supply is much more likely to lead to a problem for the cells there. There are also some definition problems. We use serum creatinine, but we know that that doesn't necessarily reflect filtration. We also use filtration, but we know that that doesn't necessarily reflect renal function. And similarly, filtration and injury are not actually strictly coupled. If you have a severe dehydration in an animal model and you take the kidneys out and you look at gene expression in them, there's actually very little gene expression of injury there. Again, this array is highlighted there, again, just showing you what type of nephrons these might be. But the important bit is the graph on the right, because that demonstrates what the distribution of these nephron types is likely to be across CKD states. So in kind of CKD 0 and 1, you're likely to have a distribution like the blue peak there, where it's predominantly very happy greenish nephrons and maybe a lot of pale green nephrons. As you move to CKD 4 and 5, you're much more likely to have these kind of unhappy-ish nephrons. And the point is that the state of unhappiness on this spectrum leads to a graded response to the stress that you get. What kind of stress response do we get in these cells? Well, generally, we know that they develop an inflammatory state and they'll upregulate all kinds of genes which lead to protein secretion, such as cytokines, adhesion molecules, and defense molecules. Now, these three that I've indicated here are actually new acute kidney injury biomarkers. And actually, it shows that the pathophysiology on a molecular level is very intricately tied to how we can detect. What's the result of secreting these proteins? Well, there's a huge influx of immune cells into the renal parenchyma. It damages the renal microcirculation and it causes further tubular damage. In addition to that, what happens is that the cells, they shut down metabolically. And you can imagine a pale green or an amber cell is much more likely to become red because it's already on a knife edge as compared to the intense green ones. When they shut down, all those functions shut down with them, including the hyperfiltration that's going on in the CKD nephrons. These tubular cells will then enter cell cycle arrest because they think they've incurred some DNA damage, and they'll do some checks and they'll make a decision on whether to survive or not. Now, the other thing is that these two molecules here are cell cycle arrest markers, and this is also a very new acute kidney injury marker, again, indicating the deep links between the cellular pathophysiology and our detection. But what we know is that then that means that a lot of these cells are going to be dying, and that's going to be driving nephron dysfunction. So coming back to our original example, actually the happy kidney that we had beforehand may well actually be made up of a bulk of functionally normal nephrons, but ones which are metabolically slightly abnormal. And this might be the case in somebody who's got diabetes, no diabetic kidney disease that's detectable because there's no proteinuria, but actually they've got very subtle metabolic dysfunction within their tubular cells. They've got a much higher degree of lipid droplet deposition and so on. Now, when the kidneys develop acute kidney injury, they can enter one of these three exemplar states. At the bottom, we've got the old state where there's a predominant loss of nephrons in a very poor state. On the other hand, you can still end up with this eGFR of 50, or sorry, actual GFR of 50 through a variety of arrays of color. And the job of the anesthetist is to try and provide the very best conditions to, first of all, prevent kidney injury, but secondly, when you get kidney injury, to make sure that you avoid the bottommost outcome and you push towards either the middle or the top. And the reason for that is because even at the same GFR, these higher states are much more likely to recover quickly, and you're much less likely to get CKD in the future. And then that's just repeated for the GFR for 65 as well. Obviously, it can't go to this top state, but again, our job is to try and push towards a condition where recovery is more likely. So how can we do that? What do we have in our toolkit? Well, there's fluids is the first thing. So this is a randomized controlled trial looking at liberal versus restricted fluid therapy. And although there's very many different definitions of liberal and restrictive, what this one, liberal therapy is much less likely to result in poor renal outcomes. What's interesting, though, is that those kind of MAKE 365 outcomes on the death side and survival side, they weren't affected by this. So there's a kind of a disconnect between the AKI that we see in observational studies and the actual translation to improved survival. We know from observational data that there's a very strong link between intraoperative hypertension and the risk of AKI. And this study decided to clamp blood pressure within 10% of baseline for the treatment group compared to standard of care in the non-treatment group. And what they found was that their overall MAKE 365 type outcomes were significantly improved with this strategy. So keeping your blood pressure higher is better. But what was really interesting was that when they went into the secondary outcomes and they looked at, did this work for the kidneys, actually there was no effect on the kidneys. So again, there's this slight disconnect. What about goal-directed therapy using these vasoactives and these fluids differently? Well, this is a sub-study from the OPTIMIZE study. And they used the urinary biomarker NGAL to look for kidney injury. And unfortunately, they were unable to show any difference either in their primary outcome in the main study, and in this study, no difference in AKI, according to NGAL. So does goal-directed therapy fail? Is it not working? Well, this is a different study which used the novel marker based on the cell cycle arrest molecules. And what they did was they stratified patients into high risk and low risk. So your patient has the operation, you do the point of care biomarker. If it comes high, they're high risk. You then randomize those patients to goal-directed therapy or not. If they were in the goal-directed therapy group, what you see here is that there's a significantly reduced rate of acute kidney injury and moderate to severe acute kidney injury as well. So maybe goal-directed therapy directed in a more precision-oriented way is the way forward. Now, I've talked a lot about energetic status and metabolic dysfunction in these tubular cells. This was a way of trying to boost the energy levels in those cells by giving patients nicotinamide. It actually comes from cardiac surgery. It was published in Nature Med. It's a fascinating study. I recommend you go and read it. But essentially what they did was they were able to show that they were able to bolster cellular energy levels, and they showed that there was a lesser degree of kidney injury consequently. Last couple of slides. As far as pharmacology is concerned, there have been attempts to try and improve the microcirculation through the use of aspirin, but if anything, that showed a higher rate of kidney injury, and to try and dampen down inflammation with clonidine, but again, no effect on kidney injury. So what else can we do? Well, maybe once our patients have been discharged, the ones with kidney injuries, maybe we should give them renoprotective medicines. This study was retrospectively done, propensity matched patients on ACE inhibitors and not ACE inhibitors after ICU discharge who had AKI. And what they showed was there was significantly improved survival in these patients on ACE inhibitors. Maybe we need ACE inhibitors, maybe we need SGLT2 inhibitors, I'm not quite sure, but that's potentially a way forward. So we know that AKI is common. We know it's associated with not just inpatient, but post-discharge long-term harm. And so because there's relatively little that we can do for it at the moment, it's quite important to identify these high-risk patients at the moment. Try and do the simple things like getting the right surgery for the right patient. Don't minimize the trauma if we can. Halt preoperative ACE inhibitors and angiotensin receptor blockers. Try and optimize perfusion intraoperatively, avoiding nephrotoxins. And once AKI has developed, be as sensitive as you can to the kidneys with minimizing secondary injury. And we're not really there yet, but I suspect very soon there's going to be trials of probably SGLT2 inhibitors post-AKI, and that may be a way forward. Thank you.
So if there are any questions for Dr. Mansoor. So one of the questions that I had in my mind was the role of biomarkers in terms of predicting intraoperative or post-operative AKI in the immediate post-op period. So can they be used as a guide, as these patients are going to need higher levels of support or possibly renal replacement therapy?
Yeah, so I think the evidence for that is in development. I mean, there was the study that we looked at here with the cell cycle arrest biomarkers, where once they identified that the patient was having the AKI at a very early stage, they were then able to direct therapy. That suggests that this is a strategy that could be useful, but I think that's the only study that's shown it. So another one in cardiac surgery, which has used the same AKI biomarker, and they've also had some positive results. But these have both been relatively small trials, and what we know is that when we tend to stretch out these trials to sort of several hundreds, if not thousands of patients, we often end up losing the signal that we had initially. So that's something that's featured with the goal-directed therapy trials in major surgery and in emergency surgery as well, that, you know, the initial signals of a really beneficial therapy seem to have been somewhat lost. That's what we found with Optimize. So I'm hopeful that that's a way that we can go forward, but I think we're not there yet, really.
We have another question.
Yeah.
So do you think there is a role for remote ischemic preconditioning in preventing AKI post-operative?
Yeah, so remote ischemic preconditioning is really interesting. And I think, again, the studies on that have been very variable. So there were a couple of early studies which suggested that there may be some benefit. Some of them have also not really looked strictly at acute kidney injury. Some of them have been looking at myocardial injury. But again, on the larger trials which came out, I don't think that there was any data that strongly suggested it was of benefit. I think we probably need to repeat the trials in probably larger groups of patients and specific patients, because, as I said, it's been looked at in cardiac surgery, but the cardiac surgical patients are slightly different to the non-cardiac surgical patients.
Question number 2 was, you mentioned stopping ACE and ARBs preoperatively. Do you have data to back that up, that specific intervention?
So there's no randomized controlled trial data of stopping them. But so far, if you look at other papers and studies which have looked at predictors of acute kidney injury, so one of the biggest ones is the recent one from Korea with the SPARC predictive score. They also score ACE inhibitors and ARBs preoperatively as a risk factor, strong risk factor for acute kidney injury. At the moment, on the basis of that observational data, which we seem to have reconfirmed here as well, it would seem sensible to do that. There is, I know, an interest in actually trialing ACE inhibitors in these patients, but not specifically for the outcome of kidney injury. It's more in the sense of whether or not they're cardioprotective. So there's a couple of folks out in London who've got an interest in perioperative myocardial injury, and they've been pursuing the beta blocker angle, and now they're wondering about moving on to the ACE inhibitor angle. So I suspect that if that goes ahead, just like the POISE study with the aspirin and clonidine, which I showed earlier on, that was actually a myocardial injury study, but they ran a sub-study or they ran a parallel study for renal outcomes. So I suspect if that comes forward for cardiac, they'll probably look at the renal outcomes, because it's obviously the biggest relative contraindication to doing the trial. But there's no hard randomized control trial evidence that you should stop ACE inhibitors and angiotensin receptor blockers. But, you know, I think if I was in pre-op clinic and I saw a patient at very high risk of acute kidney injury, it would be probably a drug that I'd advise them to stop at least 1 or 2 days before coming.
Thank you.
Thank you very much. That was a great talk. Makes me nostalgic for work, so I might go back. I just wanted to ask you about, you mentioned anemia as a risk factor. And we've had the PREVENT trial, which showed the futility of iron therapy in correction of anemia preoperatively. Have you any thoughts on, first of all, why these patients have, why is anemia a risk factor? And secondly, how should we manage the patient in the pre-assessment clinic who turns up and has anemia? is going for major surgery?
Sure. So I think that's a great question. And I'd imagine even the people that ran the iron trials don't really know the answer, but I mean, I'm happy to speculate. And, you know, the easiest way of looking at it is to go, well, if you're anemic, you've probably got less oxygen delivery. And maybe that's why when you have the stress of some hypoperfusion insult, there's a bigger response. I actually don't believe that. My impression is that anemia reflects something fundamentally about the patient. I think this might tie in with our findings that heart rate was linked with acute kidney injuries. And what anemia, whether mild or moderate or severe, and also these rather odd bone marrow indicators of inflammation, such as platelet to lymphocyte ratio, neutrophil to lymphocyte ratio. I think what they indicate is the kind of the life history of the patient. If you look at patients who have got these slightly abnormal parameters, they tend to be insulin resistant, they tend to be hypertensive. If you go and look at the hematology and hematology oncology fields of medicine, they've now shown that there are some clonal abnormalities in patients who have these bone marrow abnormalities. And those clonal abnormalities from the leukemia perspective are of interest to them. But what we found is that their immune cells are much more reactive in response to stress as compared to normal immune cells. And we know that part of the acute kidney injury response is actually immune-based. And my suspicion is that actually what this represents is patients who have overall reduced cellular resilience in their bodies. And in addition to that, are hyperreactive in response to trivial stresses. So I think that there's a synergy that's going on there. And I suspect that, you know,
Opioids are used as a part of multimodal regimen. Techniques to replace or to reduce the perioperative use of the opioids. Bit of the historic background, there was 1853, that was the first reported use of subcutaneous morphine. Okay, it's more than a century. And then we are talking about the semi-synthetic opioid, and heroin was the first semi-synthetic opioid which was launched in medicine as well. That was in 1898. Then comes the 1926, comes the concept of the balanced anesthesia. People started at least wanted to use something else other than ether anesthesia, and they moved from the ether anesthesia to the concept of the balanced anesthesia, for which the opioid was the main target. Fentanyl came into anesthesia practice, that was in 1962, and at that stage, because of this hemodynamic safety and hemodynamic stability of the fentanyl, is still the main use of the opioid intraoperatively. Then in 1990s, it all started, which we later termed as the opioid pandemic. We started using a lot of opioids perioperatively in outpatient setting as well, because there were a few reasons why we were so keen to use the opioid, because of loosen restrictions, and we started using the opioid for the non-cancer pain as well. And around 2000, because the pain was considered as the fifth vital sign in the hospitals, we are getting more and more keen to prescribe opioids to control pain. The next one, from 1997 to 2007. This gives you an idea how big jump of this in the sale of the opioid. Overall, it was 150%, but especially for OxyContin, it was actually jumped to more than 800% in this 10 years. And in 2010, hydrocodone and the paracetamol combination was the most prescribed medicine at that time. So that's how the opioid use. And okay, the other important thing is this all figures, and this story is basically mainly from the Northern America and Europe as well. We don't have all the facility of having all these opioids in our country. So this is the whole spectrum. So we started from the opioid-based anesthesia. Okay, then we started about the opioid-sparing anesthesia. Should we move to the opioid-free anesthesia? There's still the question mark on this. And a bit of basis of the opioid-free anesthesia. This is purely a textbook picture, and you are all familiar with the textbook picture of the physiology of the pain, the transmission, and how we perceive the pain perioperatively or otherwise as well. While straightforward, another textbook picture of the pain pathway, where we can block the pain pathway in perioperative setting or otherwise as well. What was the driver of the opioid-free anesthesia? That was our overreaction to the opioid crisis in the 1990s and still going on. As far as the opioid-free anesthesia is concerned, we are basically taking to the opioid-sparing concept to the extreme. And some people also blame the RAS guidelines, or rather, I would say, misinterpretation of the RAS guideline to use less and less opioids. There was at least experimental studies, or we can say preclinical studies of the use of opioid in the oncological surgery, and people got getting proof, at least on experimental basis, especially regarding the morphine, then how the morphine can lead to angiogenesis and to metastasis of the cancer, micrometastasis of the cancer. So it should be avoided in cancer surgery. Look at this picture. This is a simple opioid consumption, and this goes by the country that mainly this is Northern America. We are talking about all the opioid pandemic and the use of the opioid increase over the decades. European country, I would say, are more sensible in the opioid use. So there was definitely a big increase, but not to that extent. But if you come down to this line, probably the Pakistan is further lower on this graph if we're talking about the overall opioid consumption. But globally, the opioid consumption has not gone up as expected. The next is looking at the same crisis with the different levels and talking about the different opioids, which will actually involve in the, medical use and rather misuse. And the overall opioid consumption has gone big high. But if you specifically look at the different opioids, fentanyl has gone much bigger way in terms of the black market, or you say illicit drug market as well. And it's maybe the most commonly used drug in North America in the illicit market, while heroin has actually not been that high, going high up. And the overall, the consumption is not big. I mean, we talk about the causes of death at this stage. So all the opioids are not blamed from that point of view. If you talk about the literature for the last 10 to 20 years, they are actually in every international journal, you will find a lot of description about the opioid misuse and opioid-free anesthesia. People, it's a sort of a hot research topic, and people are going in different countries and different journals talking about the different opioid-free analgesia or opioid-sparing anesthesia, good, bad, all these things. That's one for the term in terms of the opioid-free anesthesia for the oncological surgery. So why and how, what's the analysis? So these are all things that are going on. As I mentioned earlier about the opioid and the cancer, the opioid immunomodulation was to be blamed. The natural killer cells was to be considered to be the target of the opioids in the spread of the macrometastasis. The opioids are thought to bind on the receptor in the tumor cells. They may favor the tumor angiogenesis, its growth, or the metastasis. These are the different options. Rather, it is sort of you talking about, if you like, this concept of the opioid-free or opioid-sparing anesthesia. This is the main slide we are talking about at this stage. What else pain medication we can use to replace the opioids? The regional blocks are the main targets, either neuraxial, intrafacial blocks, or the peripheral nerve blocks. Actually, in our Shaukat Khanum clinical practice, we rely a lot on the regional blocks. Any major surgery we are doing in our hospital, we rely on mainly these types of blocks, either truncal, epidurals, or the peripheral nerve blocks. IV lidocaine came in a big way earlier on, but not much as used nowadays. Paracetamol and NSAIDs, they are rather would say the mainstay. But just keeping in mind, you can't expect from paracetamol to replace the morphine. So just keeping in mind, it can work up to 30 to 40% of the analgesic requirement, but not as a replacement for the morphine. Perioperative gabapentinoid, okay, again, this came is historically been used for the chronic pain, but again, people in the last 2 decades, people started using it for the perioperative and acute pain. But okay, unable to find strong benefit. And there are a few articles in terms of the gabapentinoid that the bubble has deflated by now. Ketamine is an old drug, and people are in our hospital as well. People are using ketamine as an analgesic dose. There were the interesting articles where people started using ketamine in combination with dexmedetomidine. So the idea is to use the side effect and to control the side effects of one medicine with the other medicine and get the benefit. If the dexmedetomidine causes bradycardia, so why not mix bit of ketamine along with it to support some sort of tachycardia, secretion issue. So there were a few articles, actually they all came from the Indian journals, and apparently they are using it extensively to replace as a opioid sparing technique in their practice. Magnesium sulfate, IV magnesium sulfate has been used, and we are also using in our hospital as well, especially for the head and neck surgery. And we talk about use magnesium sulfate for all the benefit in the opioid reduction in the opioid consumption perioperatively. Now, the last one, the opioid sparing opioid. This is another interesting concept. They started using, people have published on methadone. So if you give methadone perioperatively, the idea is it's long acting, and we're talking about the major and complex surgery, especially spine surgery, cardiac surgery, and all this stuff. They started using methadone preoperatively or intraoperatively, and they have shown that the overall period use of opiate, they included the period of the postoperative. Some of these studies, they included a week even after the surgery was done. So, but they have shown that the overall consumption of opioid intraop and perioperatively has been reduced by the use of methadone intraoperatively. Interesting idea. The blame of the ERAS, okay. The people who are proponent of avoiding opioid, they always quote the ERAS guidelines to be shown that opioid should be used minimum or should not be used. Just keeping in mind that the original components, there were 5 original components of the ERAS when it came, only one was anesthetic component. And this anesthetic component was actually the epidural, and they were talking about the open colorectal surgery. Anyway, all these things started from the ERAS as well, and people are more keen to add more elements of how to avoid opioids perioperatively for the ERAS pathway, okay, for unknown benefit, but maybe more risk. So the recent guideline, that's why from the World Journal of Surgery, as from this one, they mentioned that the analgesia best provided by opiate sparing, not by eradication. So that's the recent guideline from in terms of the ERAS. Same pendulum, we are talking about the pendulum, we are swinging, where can it stop and where can we find the Goldilocks zone for the opioid? The benefit, we can get the maximum benefit opioid with minimum side effect. All this progression, there was an interesting analysis, there was from the anesthesiology, when they were commenting on the opioid. Yeah. That's interesting progression of the value. Is it feasible? Yes, it's doable. People are doing it, it's doable. It's viable, at least in some type of surgery, it's viable and people are getting benefit of it. Is it worthwhile? Can it fulfill the patient need? Okay, some evidence, not the strong evidence. Is it desirable? Not, at least not demanded by the patient, not to give me the opioids. Not shown until now that it has improved the outcome of the major surgeries. So still hanging in there. So I'm just coming on this whole perspective from different angle. So just keep in mind all the opioid crisis or opioid pandemic, this was basically the excessive outpatient prescription, not the perioperative use in the West. In Pakistan, we have restricted availability of all sorts of opioids, and it's very difficult to find, even in the tertiary care hospital, we are difficult to find the adequate opioid for our patient, not to talk about the peripheral hospitals or in the smaller hospital. So multimodal analgesia approach is actually more suitable for our setup. We should, from the training point of view and from the usage point of view, when we have a limited availability of the opioid in our country, in our hospitals, why not to use this technique, not for that reason, but for this reason. So we should develop more competency and more rather research as well, say how far we can use the multimodal opioid sparing technique in our patients. As learning curve, yes, it definitely is a learning curve. Something is coming up, but one thing is very clear. This is an exciting field of research, the growth in the research from this topic, and we should go for it. Keeping in mind that our primary goal is the better pain control management, not the reduced opioid consumption. And to summarize all these things, I can say it's difficult to avoid perioperative opioid completely in all cases. This might be a wishful thinking, but multimodal opioid analgesia and regional techniques will definitely use the opioid we need perioperatively. Multimodal opioid sparing approach should be the primary choice whenever possible. An opioid can be used as a rescue analgesia. We should look for more benefit with less risk rather than more risk than less benefit. So that's the whole talk about. If you want to ask in terms of this question, as I earlier mentioned, that I try to practice the opioid sparing anesthesia practice in my routine clinical perioperative care. Anyway, any question in terms, you're most welcome. Thank you.
I would request everyone to keep the questions for the end. We are a bit short of time, so we can take the questions at end. For the next talk, I'd like to invite Dr. Jain again. Her topic of presentation is cardiopulmonary exercise tolerance. Thank you.
So, surprise, it's not the national audit of hospital mortality. Unfortunately, the data that I was hoping to show is not available as of now. I don't know whether people know, but our health service, the health service executive, was subject to an attack on our IT systems, which actually essentially closed them down for 3 months. And it's had a huge effect on our ability to produce the usual data that we would in terms of regular reports. So I thought that this talk would be fitting for a replacement talk. So cardiopulmonary exercise testing for risk assessment in cancer surgery. So not new, actually. Gordon Lambert was a doctor in Reading in the UK, and you'll see the date of this publication is 1980, so just over 100 years ago. And he was working in a hospital called the Battle Hospital in Reading. And the Battle Hospital was so called because that's where soldiers from the trenches were brought to if they needed further treatment, surgery or medical treatment. And Dr. Lambert and Sister Doherty undertook this test, which was the effect of a walk test or stair climb test on heart rate, blood pressure, and respiratory rate. Dr. Gordon stood at the bottom of the stairs. Sister Doherty was at the top to greet the patient. And they rated them as good, fair, bad, or very bad. Is that new or not? This is exactly what we've been doing since then. Now, cardiopulmonary exercise testing of this nature has been used by cardiology and respiratory services since the 1920s. Knowing the risk, NCPOD in 2011 showed that elective high-risk patients had a 7-fold increase in mortality if they were not pre-assessed. So accurate risk assessment is essential to inform the discussion of risk versus benefit of surgery, and it may also inform resource allocation focused on the patients who need it, such as a rehabilitation and critical care admission. So in 2018, we looked at cardiopulmonary exercise testing. There were over 90,000 publications. In 2009, Mike Grocott from Southampton had done a survey of hospitals in the UK, and at that stage, 44% of patients of hospitals at CPET facilities. By 2018, it was more widely available in the UK, and we had the establishment of the Perioperative Testing and Training Society, or POETS, in 2017. And Danny Levitt, again from the Southampton group, produced consensus guidelines on indications, organization conduct, and physiological interpretation of preoperative testing. So I would recommend these guidelines to you. They're available from the BJA 2017. So what happened then, of course, was we had COVID, and CPET testing was very much affected by COVID because of the close proximity, aerosol generation, and that I think put a little, you might have thought would put a stop to the gallop of publications coming out, but we now have over 123,000 publications on CPET. So it is more widespread, but it's not universal. And in where I work in the Republic of Ireland, it's only available in major centres. And an interesting thing that I came across was that centres without CPET testing in the UK have been shown to have a higher mortality. And I would say at this point in time, CPET has definitely got an established role in patient management. The European Association of Cardiovascular Prevention and Rehabilitation and the AHA issued a joint scientific statement in 2016 supporting application to preoperative testing. And the American College of Chest Physicians recommends CPET since 2007 in lung resection workup. So what's the evidence? And again, I'm sorry now if this is boring for you, but just about everything that comes out is from Mike Crocut's group in Southampton. They have researched and published extensively on it. So looking at 2011, 2015, 2011, they've looked at the elderly, they've looked at risk prediction and major abdominal surgery, and they, of course, have looked at evaluation of perioperative risk in non-cardiopulmonary surgery in 2011, and again more recently in the MET trial. So there have been systematic reviews, and we undertook a systematic review in 2016, the role of cardiopulmonary exercise testing in patients undergoing intra-abdominal surgery. So we wanted to quantify the optimal CPAT variable, which predicted post-operative outcome. We wanted to identify the most accurate CPAT variable for different surgical subgroups, and we wanted to also to look at post-operative outcome, including all-cause mortality and morbidity and length of stay. Oh yeah, okay, this one here. That's great. All right, thank you. So results, so over 1,000 papers identified, over 1,000 papers excluded, and 37 full text patients with nearly 8,000 patients. So here are exclusion criteria, and here are results. Now you will note that there are some non-cancer patient groups in this, but they're small, bariatric, renal, and aortic aneurysm repair. And I'm just going to focus on the cancer patients. So what were our challenges? The challenges again were the patient cohorts were extremely heterogeneous. The CPET parameters reported were variable. The length of follow-up variable. Complete lack of consistency in reporting complications, and some studies inadequately powered. Bias and confounding were rife, but they were assessed with the Quality in Prognosis Study tool, or QIPS. So type of surgery, CPET, even the parameters, the CPET parameters selected, was it distance, was it an incremental shuttle walk test, was it the treadmill, was it the cycle ergometer? CPET variables were measured, were also variable, and the outcome measures were variable. The time points used were variable, and the use of hazard ratios and odds ratios made it very difficult, and a meta-analysis actually was not feasible. I'm just showing, don't get upset about these, don't even try and read them, but I'm just showing you these slides to just to emphasize the small sample sizes in a lot of the studies and the variation in terms of what they were looking at, what they also measured in terms of the variables, the CPET variables reported, and the type of CPET that was undertaken. So we'll skip these very quickly. So just looking at a few take-home messages. So anaerobic threshold for hepatic surgery, an anaerobic threshold of less than 9 mils per kilo per minute predicted 90-day mortality. Less than 11.4 mils per kilo per minute predicted 1 year mortality. And there is some evidence that 16.5 to so over 16 to 18 mils per kilo per minute will increase of a VO2 peak, will increase long-term survival. But less than 9.2. So 9 seems to be a magic number for your anaerobic threshold, 9 mils per kilo per minute, increased ICU stay. So, and also predicted cardiopulmonary complications. For colorectal surgeries, this paper looked at 269 patients. Anaerobic threshold was looked at, so over 11 mils per kilo per minute, less than 11 mils per kilo per minute, and patients who were unable to generate any sort of anaerobic threshold. So there was a mortality difference at 30, 90, and 90 days and 2 years, and this was statistically significant. Again, morbidity in colorectal surgery could be predicted if the anaerobic threshold was greater than 11 mils per kilo per minute. There was a lower length of stay. Again, is statistically significant. Pancreatic surgery just showed there was no correlation between anaerobic threshold and mortality, but there was with length of stay, and if over 10 mils per kilo per minute of anaerobic threshold, there may have been lower postoperative complications. Insufficient detail on the upper GI papers, but lower anaerobic thresholds seem to be predictive of morbidity. And for general surgery, which did include all types of general intra-abdominal surgery, not just cancer, again, around the 11 mils per kilo per minute anaerobic threshold may predict mortality and morbidity and higher risk. High again for urology, the anaerobic threshold really seemed to be what was important. So what would we say about CPET in risk assessment for major cancer surgery? I would say that CPET results may predict surgical outcomes. CPET derived cut points for different procedures to be refined and optimized, and the validity of CPET variables requires further analysis. And the question has to be, well, what is the role of cardiopulmonary exercise testing in risk stratification? Because that's actually what's important to the patient. What does it mean to me? And what can I do to improve my odds, my chances? So what we surmised from our systematic review was that CPET, it is an objective fitness tool assessment. The studies to date are very diverse. Further studies need robust standardized methodologies to evaluate length of stay, critical care requirements, perioperative and long-term morbidity and mortality at 30 and 90 days, and at 1, 2, and 5 years. And when we do look at 5-year survival for cancer diagnosis, so why don't we look at 5 years survival as part of our assessments of our interventions? So standardized, and we also recommended that there should be standardized collection of morbidity data using the Clavian-Dindo scoring system and POMS. What are the alternatives to CPET? Well, there are alternatives, and CPET is labor intensive and expensive, and you may have to question as to whether it needs to be applied to every patient undergoing a high-risk surgery. So 6-minute walk test, very easily applied, very low cost, though not without cost, but it does not predict, according to this sub-study of the METS study, which we'll discuss in a minute, it doesn't predict outcome or disability-free survival at 12 months. And that's looking at 574 patients from the METS study. But what we can say is that the Duke's Activity Status Index predicted 12-month disability-free survival. The 6-minute walk test compared well with CPET. And there's another paper, again, a sub-analysis of the METS trial from Rydell's group, which was a modified Duke Activity Status Index. And that is something that they recommended as being useful. Just to say what the Duke Activity Status Index consists of 12 questions, and Rydell's group looked at the p-value for each of the questions in terms of predicting VO2 of greater than 16 mils peak. So actually the questions, there were 4 questions that came out of those 12. Are you able to climb up a flight of stairs or walk up a hill? P-value 0.03. Are you able to do heavy work around the house? P-value less than 0.01. Are you able to do yard work? Because this is, of course, this American. And the p-value was 0.04. Are you able to have sexual relations? And are you able to participate in strenuous sports? So these seem to have a statistical significance. So again, looking at this study, the MET study, this is an assessment of functional capacity before major non-cardiac surgery. And it was an international prospective cohort study. It was carried out between March 2013 and March 2016. There were 25 centres in the UK, Canada, New Zealand and Australia. And they recruited 1,400 patients who were aged 40 or over with one or more risk factors for cardiac complications or existing coronary artery disease. Their primary outcome was all-cause death or non-fatal MI within 30 days postoperatively, and the secondary outcome was all-cause death within 1 year. So this is what they looked at. So four different methods of assessment. Number one was an experienced consultant anaesthetist in the pre-assessment clinic doing a subjective assessment of metabolic equivalent training. Poor, less than 4, moderate 4 to 10, and good, greater than 10. CPEX, standard CPEX in a physiological laboratory, using the Duke Activity Status Index, and they also measured NT-proBNP in all their study patients. ECG, troponin, and creatinine was done on day 1 to 3 postoperatively on all patients, and all patients underwent the ERAS program. So the results were that 2%, 28, died or had an MI within 30 days. Subjective assessment was absolute rubbish, and it had a less than 20% sensitivity for identifying the inability to attain greater than 4 months during CPET. And the only thing that was associated with predicting primary outcome was the Duke's Activity Status Index. Oh, sorry, just skipped. So in conclusion, I would say that CPET should be included in assessment for liver, pancreatic, and intra-abdominal surgery aortic aneurysm repair. The anaerobic threshold, as I said, was the predictor of outcome for liver, pancreatic, and intra-abdominal surgery. And we can say unequivocally that an anaerobic threshold of less than 9 mils per kilo per minute is associated with increased morbidity and mortality. But other modalities could be used for screening. So where do we go with this? Well, I think we need to focus our resources everywhere on high-risk groups. For those high-risk groups, should we be looking at cardiopulmonary exercise testing and dynamic echocardiography? Should we be focusing on patients who've had neoadjuvant chemoradiotherapy and the elderly, or those with cardiopulmonary diseases? And we need to look at the effects of the interventions pre and post-operatively. What is the future? I suppose that cardiopulmonary exercise testing in pre-assessment has expanded the role of the anaesthetist as a perioperative physician. It does give us an opportunity in the pre-assessment scenario to influence lifestyle changes, challenge patients to change, and we need to evaluate the long-term benefits. But it does require investments and it does require staffing. So it may not be feasible, and it actually is not, maybe not necessary for patients, for every patient undergoing major surgery to undergo cardiopulmonary exercise testing of any kind. But we did show that the experienced anaesthetist is no judge of fitness in terms of ability to exercise. So thank you very much. And I just acknowledge the work with the Department of Physiotherapy in UCD. And these were some of our funders. Any questions? Oh, we leave questions? Yeah, okay. Thank you.
Thank you so much, Dr. Jain. I would request you to take the... so we have a panel discussion now that will be briefly of 15 minutes. And the topic for the discussion is role of general anesthetist and the era of subspecialties and supraspecialties. So in the panel, we have Dr. Raza Mehdi, Dr. Mansoor Nawaz Pangush, Dr. Jane Moriarty, and with us, we have Dr. Ehtesham, who is online from abroad with us. So I'll start with one of our panelists, Dr. Jane. What do you think that the introduction of the subspecialties has done with the role of general anesthetists? Do you think that the need of general anesthetist is decreasing as we have different subspecialties being introduced?
Well, I think that that's a risk. That is what will happen. But I would have concerns about the diminution of the role of the generalist. And I think that what you have to do is look at your population and what type of service you need to provide to that population and ensure that you actually have the right people in the right places. And the way that we would do that is to make sure that we're working in conjunction with the health planners to ensure that our training is suitable to meet the needs of the healthcare system, wherever it is. And I think looking at somewhere like Pakistan, I think that it would be extremely difficult to get off, if you want to put it that way, get rid of the generalist. Because even if you look in developed countries, a huge amount of surgery and anesthesia, it's actually not high risk. It's not at the higher specialist end. It's actually more minor surgery. And I think that you also have to think about the on-call commitments and who's going to deal with the patients 24/7.
Thank you. So Dr. Mansoor, I would come up with a question for you that since you're working in the NHS currently, and do you think that the nurse practitioners, they are taking over the role of the general anesthetist? In our part of the world, in the developing sector, there is still a lack of specialized centers. But talking about the developed areas in the developed countries, there are specialized centers. You have developed subspecialties, pain medicine, neuroanesthesia, cardiac anesthesia, pediatrics, and we can go on. So do you think that the general anesthetist, people who have not specialized in any subspecialty, they will be replaced, or maybe can you say that slowly and gradually the nurse anesthetists can take over their role? What's your opinion on that?
Well, I think there's no doubt that there's an increased presence of nurse anesthetists and non-medical anesthesia practitioners. I mean, in a sense, we're all anesthesia providers. And so there's no change. There's probably, in fact, an increase in the amount of anesthesia that is being provided to patients. From the perspective of the generalist, I think it's not so much that these people are replacing the generalists, it's that there's a huge burden of labor, and systems such as the NHS, they have financial constraints put on them. There's always issues with training numbers as well, and this is probably one part of a solution to a labor crisis. So I don't think that these people necessarily replace us. I think they complement us. Nonetheless, it's true that they will take on a lot of roles that were previously done by medical anesthesia providers. And that might be seen as somewhat of a threat, especially when there is much more super specialization in the West. So, having these two phenomena happening simultaneously can look like it's producing a squeeze on the generalist. But I don't actually believe they're going to replace the generalist per se. I think, there's still a massive role for the generalist, even in the West.
Thank you. And Dr. Raza, I'll come over to you, please. So since you're working here, you are in Pakistan. So what do you see what is the scope of the subspecialties in Pakistan currently? Do you think that the number of people going in subspecialties have increased over the last decade, or what do you see the future like? Do you think that there will be more specialized centers, or there will be more general centers where all sorts of surgeries are performed, and there will be a more need for the general anesthetist rather than a specialized person?
Okay, let me put it in this way. We definitely need super specialist doctors and anesthetists. That's definitely a requirement. We have some centers. So again, subspecialty center or super specialty center, whatever you call them, we need the doctors for those centers as well. But you look in grossly in Lahore or in Pakistan overall, the demand for the generalist is much more than the super specialist. Wherever you put the figure, either 80-20 or 70-30, but you have to put some figure that you definitely need majority of your trained anesthetists should be generalist, but you need some portion of that as a super specialist. We have some hospital with big training centers or in major cities, but just keep in mind, we do need a large number of the generalists to
Yeah, so talking about Lahore, yes, we do have specialized centers, but if we talk about the suburbs and the areas, rural areas, so we don't have any, I don't think so. We have much of a specialized centers there.
Yeah,
so,
I mean, really talking about the district centers, the DHQ level centers in Punjab. So they need more generalist, maybe occasionally super specialist.
Okay, thank you. Dr. Ehtisham, if you can hear us, please.
Yeah, I can. Yes, I can hear you.
Sir,
yes, I can hear you.
Yes, I can hear you. Yeah, thank you. So, sir, my question from you is, what do you see that?
I lost.
All they didn't change, but I had other colleagues in our department, and it was a relatively big department, who wanted to change, and change was facilitated so that they could actually rotate through different subspecialties. I think the important thing is, from a point of view, of course, of a resident, the important thing is getting a training that gets you a job, I suppose, is foremost in your mind. You're not really thinking about what does the country need. You're thinking about what do I need. Sure. And you know, if you're working in a place, and Ireland would have been like this when I was a trainee, you had to leave. You absolutely had to go abroad. You would not get a job unless you had gone abroad and done additional training. Nowadays, we have an educational and training system set up that allows people to do their subspecialty training in Ireland, and people are getting jobs who, for family reasons and other reasons, can't travel abroad. They are getting jobs as you know, with a specialist interest.
Thank you, Dr. Jain. Dr. Ehtisham, can you hear us, please?
I can. Yes, I think I'm back.
For the technical glitches. Sir, my question from you is, what are your views on the era of subspecialties? Like, we have taken the views of our respected guests here. So what is your view on subspecialties, and what do you think that, you know, is the future for a general anesthetist? Is it necessary for all the people to go into subspecialties, or is it okay for them to continue as they are doing for now?
Thanks, Ahmed. I think it's a difficult question, but I think there will be role of a general anesthetist and a subspecialty anesthetist as well. You cannot have only a general anesthetist trained, because there will be some subspecialty where you need expertise in a particular area. But what I have seen even in hospitals, where in Ireland we have got different types of model hospital, like say Model 4, Model 3. And in Model 4, you are doing very sub-specialized surgeries. But in Model 3 hospitals, you are doing most of the thing except cardiac and neuro and transplant. But even say, for instance, if somebody has done a sub-specialization in pediatric anesthesia, the Model 3 or some peripheral hospitals do need that sort of an expertise, obstetrics, regional, and all those subspecialty experience. So I think there is a role of subspecialty, and as long as they don't leave other specialties as well. And as you know, in anesthesia, in a European world, pain and intensive care is also part of the anesthesia training compared to the North America. So even the intensivists who have done special subspecialization, when they come up, they do participate in anesthesia as well, plus general call, and same to do in some hospitals, pain physicians as well. So I think they complement all those subspecialties, and sometimes it's good to have that subspecialty experience coming to the peripheral hospitals or where they are not doing a very subspecialized anesthesia.
Thank you so much, sir. So I would request from the audience if there is any comments or any questions that you would like to ask from the panelists. This is the time. Anything? Or regarding their talks? I guess that's it. So I thank you all. Thank you so much, sir. Thank you, Dr. Ehtesham, for being with us, and Dr. Jain, Dr. Mansoor, and Dr. Azamedi. And I thank you all. See you in the next session. Thank you.
Thank you.
We'll be here at 2 for the next session, please. Thank you.